newborn babies. You'll have a proper practical session where you practice neonatal resuscitation. You learn theoretically about how to do proper newborn examination, but you'll also come into the ward and properly examine newborn babies and do proper newborn examination. So that was the original plan. That has been the way how we do things previously. But then because of COVID, so it's getting very difficult, it's getting very tough. Seriously, I don't know how we can get this done proper face to face. We are not sure. We are not sure whether we can actually do proper. So I heard from 1st of September, year 5 can come into the ward. So hopefully we can arrange something during those times lah. For you to have a feeling of how to do newborn examination, practice doing newborn examination on newborns and so on and so forth. We'll see what we can arrange, what we can do after 1st of September. But at least for today, we learn about what to do when you have newborns to be examined, how to do and what to see and so on and so forth. Okay, all right. So the first one is the transition phases, and so how many times we do checkup, how many times we do check the newborn babies. So a newborn examination is the most thorough perinatal exam. It must be done by undergraduate or by doctors and so on and so forth. So the first phase is in the first 1 hour of life. And then phase 2 is from 1 to 3 hours, and phase 3 from 2 to 12 hours. And then we do regular checkup on the babies every first 24 hours, and then discharge and so on and so forth. So there's multiple times we go and examine newborn babies. So priorities for the first 1 hour in the delivery room and the first hour, basically again, as I've mentioned in the, give me a second. So basically the first hour of life is basically in regards to the adaptation for extrauterine life, to look at whether the baby is able to adapt to being outside of the uterus, whether the baby is able to breathe, whether the circulation, whether the baby is able to move properly, whether the good muscle tone and so on and so forth. We do proper ABGAS score assessment. We look for dysmorphism. We look for any obvious major congenital anomalies. We look for birth injuries. We look at the umbilical cord. We assess the gestational age, and we assess whether there's any need for cardiopulmonary support. We make sure the thermoregulation is being maintained properly. We assess the blood sugar, especially if those babies who are at higher risk. And then we identify, and then we initiate proper medication as needed. Okay, ABGAS score is basically we do the first ABGAS score at 1 minute of life, and then 5 minutes, 10 minutes, 15 minutes, and so on and so forth. So basically, it is designed to look for the need for neonatal resuscitation and diagnosis of perinatal asphyxia, and for prognostication. Actually, we don't need ABGAS score to assess whether the baby needs resuscitation or not. It's just that ABGAS score, I think, for nowadays is more useful for prognostication. And what do we assess? So we look at respiration of the baby, how the baby is crying, whether the baby has good breathing effort, reflexes, muscle tone, the heart rate, skin color, and extremities. So this is the ABGAS score. So this is the ABGAS score. So A is actually for appearance or color of the baby. 0, 1, and 2, blue. 2 is pink, and 1 is acrocyanosis, and then the heart rate, pulse, APGAR. Appearance, pulse, grimace, GRI, grimace, activity, and respiration. So P, pulse rate, 0 is there's no heart rate, more than 100 is 2, less than 100 is 1, and then grimace, so reflexes or irritability of the child. Whether there's no response, grimace, some cough and sneezing, they respond, they start to cry. And then activity, looking at the muscle tone. Limp, this is LIMP, limp. very poor muscle tone, there's some flexion or baby is active and moving, and also the respiration. Okay, so next is what are the other signs of respiratory distress? So we look at cyanosis. If the baby is still having cyanosis, whether there's grunting. What is grunting? What is grunting? Grunting tu apa? Siapa boleh explain what is grunting?
Nafas
Bunyi
berbunyi
macam mana?
dekat hidung.
So grunting tu bunyi macam mana? Grunting tu dia bunyi macam so bunyi macam tu apa dia buat? Dia close dia punya vocal cord and then dia increasekan intrathoracic pressure. So basically the idea is dia nak open the airway, open the alveolar by increasing the intrathoracic pressure. That's grunting. Macam kita nak buang air besar kan, kita tekan macam tu. So but it's not bawah ke bawah, but it's kita tutup ke atas ni dan kita increase intrathoracic pressure. So that's grunting. Then flaring of basically nasopharynx, retractions, respiratory rate of more than 60, then heart rate of more than 160, or if it's less than 110. So these are the other signs of respiratory distress that you need to look for. It can be because of respiratory system, it can be because of cardiac reason, it can be because of metabolic, it can be because of infection, it can even be because of thermoregulation. If the baby is hypothermic, sometimes there'll be bradypnea, the respiratory rate will be low, or it can even be tachypnea. Or if you set the temperature too high as well, the baby may be tachypnea as well. So maintenance of thermoregulation is very, very important. So how babies can lose heat? How can they lose heat? So there's several mechanisms. The first is conduction. Conduction is when surface are in contact. So there'll be heat transfer by direct contact. So that is conduction. And different material conducts heat differently. Certain materials conduct heat better. Certain materials are not good conductor of heat. And then next is by radiation. So by radiation, where the heat is lost into the environment. So it's by radiation. Next is by convection, where you give a flow of heat and or flow of cold air. But so by convection, by movement of air. Next is by evaporation. So evaporation ni apa? Is when water droplets change from fluid into vapor. So that's evaporation. So it also, you will lose heat by evaporation. So these are four mechanisms how heat is lost. If you remember, if we do tepid sponging, so among the how we can lose heat by doing tepid sponging is by evaporation. So the idea of tepid sponging ni, you bukannya jelun dengan air sampai the baby is shivering. Why? Because if the child is shivering, dia ketar-ketar because of too much water, the problem is shivering increases muscle movement because of shivering actually produces more heat. So when you do tepid sponging, the idea is to just put some droplets of water, just minimal, on top of the skin. So when these droplets of water evaporates, this is where you will lose the heat by transfer of energy. So that's evaporation. So this is how babies will lose heat. So we need to maintain appropriate proper thermoregulation. How we make sure that the baby there's no heat loss by conduction. Maknanya kena ada lah some material that does not transfer heat well by conduction. Apa contoh dia? Contohnya linen lah, kain kan? Kain. Dan kain tu pun ideally it should be a warm linen. So it reduces heat transfer by conduction. Kan? Ada tilam dia. So all these are poor conductor of heat. And then by radiation, kita kena make sure kita letak radiant warmer. So bila ada radiant warmer, it gives a heated, it gives heat by radiation. So kita kena ada radiant warmer. And then especially in term babies, kita lap, kita dry the baby. Kenapa kita dry the baby? Sebabnya bila dah dry, tak adalah fluid yang boleh convert into vapor. So reduce heat loss by evaporation. So next, vital signs. Normal vital signs in newborn babies 36.5 to 37.5 lah. And then heart rate dia 110 to 160, respiratory rate 30 to 60, lower than that or more than that is abnormal. And BP we consider mean as the gestational age. Mean we look at the mean of the gestational age. For example, for a term baby, 40-week baby, so we expect the mean blood pressure to be 40. A 30-weeker baby, we expect the mean blood pressure to be 30. If the baby is 34 weeks, we expect the mean blood pressure to be 34. So it's same. The mean blood pressure is the same as the gestational age of the baby. Okay, so sometimes newborn babies they open bowel at birth or before birth. Yeah, so we need to document. And baby should pass meconium first, and then only they pass proper stool. We need to document urination because sometimes all newborn babies the first 24 hours ni dia oliguric sikit. Kan? Tapi we are more worried kalau dia anuric, so the baby doesn't pass urine. But the thing is, some newborn babies they pass urine at birth. Kan? So that's why if the baby pass urine at birth, we need to document it and make sure that we actually noted how much urine is being excreted. Okay, all right. Next is we observe for gestational age, we assessment of gestational age by doing Ballot score. Generally, we do this for premature babies lah. We don't do Ballot score for, there's no need to do Ballot scoring for term babies as well. So it needs to be done early. The earlier we do Ballot scoring, the more sensitive it is, the more exact it is. The later you do it, less it is not that correct if you do it later. What is Ballot scoring? So this is Ballot scoring. You boleh tengok ni, if you come to NICU, go and look at Ballot scoring. So we look at the posture. This side is more premature. Can you see my arrow? Nampak?
Nampak.
So this side is premature, this side is more term babies. So you see, in terms of posturing, atas kan ni is posturing. So premature babies, the posture is a bit more extended as compared to more term babies. So term babies, they're more frog-like. They dah start more flexion of the elbows, of the knees. And then square window. So square window of the wrist. So the more premature the baby, dia tak boleh nak lipat dia punya wrist dia. The more term baby, they can flex much more. Arm recoil. So bila you letak tangan dia straight, dia biasa akan recoil dia punya arm dia. So less premature baby, less recoil. More term baby, dia akan recoil more. And then popliteal angle, scarf sign. So scarf sign ni berapa jauh you boleh tarik tangan dia, kan? So that scarf sign. And then heel to ear. We look at how many. So basically, the more premature baby, you can flex much more with the hip joint. And then skin, you tengok dia transparent skin, gelatinous ke ataupun parchment, deep cracking kan. So more term baby dia akan more premature baby dia akan nampak more shiny skin dia. Dan nampak macam transparent, nampak kulit dia transparent macam tu. More term baby you akan nampak dia dry sikit and ada parchment, ada cracking. Dan lanugo ni is the body hair especially dekat belakang tu. So term baby biasanya bald dia, tak ada pun. Kalau more premature baby you akan nampak ada banyak dia punya lanugo dia. And then plantar surface ni crease, kedut-kedut dekat dia punya plantar surface tu. Premature baby dia akan tak ada crease langsung, dia flat je macam tu kan. So kalau dia akan dia ada sikit crease and then toothed. So kalau term baby you akan nampak the whole sole dia ada crease. Lepas tu breast bud kan. Kalau premature baby tak ada breast bud pun. And then dia start akan ada breast bud and so on so forth. Dia boleh measure lah. Kadang dia areola dia flat, tak ada bud langsung. Kadang ada bud sikit. Areola, steeple areola, but dia ada 1 to 2 millimeter for example. And then ears dia, eye dengan ears dia kalau eye pun sambung, mata tak boleh buka, so very very premature baby. Kan? And then ears dia, telinga macam telinga kita kan, bila kita lipat dia recoil terus, kan? That's a term one. Tapi kalau premature baby, bila you lipat telinga dia, it won't recoil back. So dia ready recoil, easy recoil, slow recoil ataupun stays folded. Kalau you fold telinga dia, fold dia punya pina dia, the ears remain folded. So very premature baby. So that's how you do. And then you look at the genital dia male or female lah. Kan? So kalau female yang term baby biasanya dia punya majora dia covers, the minora is small kan, female kan. Tapi in more premature baby sometimes the majora and minora is a same size. So macam tu. Kalau male you tengok at the rugi of the scrotum kan. Kalau more premature baby, scrotum dia tak banyak rugi pun. Kalau term baby you nampak banyak rugi, kedut-kedut tu. Kan? So and then you put the scoring. So this is -1, 0, 1, 2, 3, 4, 5. Kita letakkan scoring dia, and scoring dia will show what is the gestational age in terms of week. So you plot kat sini. So that is a ballot scoring. Ballot scoring. So you can do ballot scoring. So ballot scoring is very good actually. So bila buat, kadang-kadang ada parents kan dia tipu date, contohnya kan, those yang married late and then premarital conception for example, sometimes dia tipu tarikh dia kan, but they don't know when the baby is born. We can actually know when the baby is actually conceived. So these are all physiological, dia tak boleh tipu kan, dia tipu lah tak my period ni bla bla baru dikahwin ni first time. It doesn't really matter because whatever we can see on the baby, that's it. So we know already when the baby is actually conceived. We know the actual gestational age of the baby. So I think this one is very interesting as well. So this is the same thing I mentioned before. Okay, so next, crack skin. Nampak kulit dia dah start ada cracks, ada parchment. And then lanugo, nampak bulu-bulu rambut. So abundant lanugo. This is a bit premature baby. Yeah, so I've told you before, kalau in premature baby, bila you fold the ears, dia stay folded. Kalau macam a bit premature, dia ready recoil, dia slow dia patah balik, dia normal, assume back normal position, kan? Kalau a very term baby, kita lipat, dia akan terus ready recoil, And then areola, flat areola, breast bud pun tak ada, dan you can see lanugo, banyak lanugo. Okay, this is the creases of the sole. So more term baby, you can nampak creases dia the whole sole. Kalau more premature baby, sole dia akan flat saja, smooth saja, tak ada crease. And then 2/3, 1/3 and so on and so forth. So and then very premature baby as you see here, the majora is small. You can see the minora and so on and so forth. So very premature baby. If you compare here, more term baby, the majora is big, minora is minor. It's very very small. You can't even see really well. So in a more premature baby, you can see the minora. And this is a term baby as well. You can see a lot of the creases, the rugae. You don't call it crease, you call it rugae, rugae of the scrotum. So this is a term baby. If a premature baby, it will be almost flat. Crease, rugae, you cannot see a lot. And then posture. You see here, the right side is a very term baby. They flex dekat dia punya elbow and flex at the knees and hip. And the more premature the baby, the more extended are the joints. So this is posture, resting posture. And then we look at reflexes. You check whether there's head lag. Obviously, there's head lag, but how bad is the head lag? You assess the Moro's reflex. Moro's reflex is very good assessment for neurological condition. Especially, it won't be present in babies with HIE, for example, or in babies with shoulder dystocia. Sometimes what you see is there'll be asymmetrical Moro's reflex. Satu tangan je yang gerak, satu tangan lagi tak bergerak atau kurang bergerak. There's be asymmetrical Morose reflex or incomplete morose reflex. So it shows that there's some injury probably to the arm, to the nerve system, and so on and so forth. Morose reflex. Rooting reflex. Right? Rooting reflex ni, if you stroke something to the cheek, baby tu akan cari. And that's rooting reflex. That's a primary reflex. Asymmetrical tonic neck reflex. Stepping reflex. Stepping reflex ni, bila you pegang baby tu, and then you put the dorsum of the foot. Dorsum, bukan, this is plantar, bawah ni plantar, atas ni is the dorsum of the foot. Kalau ni ada surface, for example ni surface, ni dorsum of the foot, you letak kat bawah ni, dia akan step atas. So that is a stepping reflex. Dia ada juga walking reflex, walking reflex. And then sucking reflex, hand and foot grasp, plantar and palmar grasp, Babinski, trunk incurvation when you stroke the back, and so on and so forth. Head leg. So babies usually have head leg, but sometimes even in newborn babies, dia ada head leg dan dia akan try nak recover balik. Morose reflex, I think we do need to practice morose reflex on patient. Bila you dropkan dia macam tu, dia akan buka and then dia akan recoil balik. It should be symmetrical. Tonic neck reflex ni is a fencing reflex, dancing reflex or walking reflex lah. If you hold the baby ventral, you letak kaki dia dekat atas dia punya atas surface tu, dia akan nampak macam dia jalan ataupun dancing. Duduk setempat tu dia macam dancing lah. Tapi kalau you movekan dia, you akan nampak macam dia jalan. So it's not a miracle, because if you see kan, ada video dekat YouTube kan, miracle baby baru lahir kan boleh jalan dah. It's not actually a miracle, it's a miracle of God, because all babies should be able to do lah. This is what you call as dancing reflex or walking reflex. Next is sucking and rooting reflex. We need to do palmar grasp and plantar grasp. And then basically when we do newborn examination, it's a head to toe examination. So we examine from the head to the end. So we assess the head circumference. We look for molding. We look for caput succedaneum. We look for cephal hematoma. What is the difference between cephal hematoma and SAH? Subaponeurotic hemorrhage. Siapa boleh cerita? We look at the fontanelles, anterior fontanelle and posterior fontanelles. Anterior fontanelle biasa dia close between 12 to 18 months, and posterior usually by second month pun dia dah close. So this is molding, maknanya kepala dia lama dekat bawah perineum of the mother tu, kepala dia terbentuk, so it's molding, M-O-U-L, salah eja. Cephal hematoma, you see here there's bump there. Kepala dia macam tu, ada bump sikit tu, that's cephal hematoma. So what is cephal hematoma? So caput succedaneum is macam edema, basically there's fluid. Tapi in cephal hematoma there's bleeding. So bleeding kat mana? What is the layers of the scalp? What are the layers of the scalp? Layers of the scalp.
Skin.
Okay. Lagi. Okay, wait. Sorry, let me see this. Okay, so first is skin, and then connective tissue, loose connective tissue. And then A is for aponeurosis, and then L is for loose connective tissue, and then P is for periosteum. And you remember your periosteum covers the bone, kan? Periosteum covers bone, betul? Periosteum covers the bone. So cephal hematoma is bleeding under the periosteum. Cephal hematoma is bleeding under the periosteum. So bila dia bleeding under the periosteum, periosteum dia covers the bone, kan? So scalp apa semua dia covered by periosteum. So if you have cephal hematoma, the bleeding will not cross the midline. Sebab midline ni kan dia ada suture, kan? Sagittal suture, kan? Dia ada banyak sutures, kan? So it will be bounded. So kalau cephal hematoma, the bleeding will not cross the midline. It will not cross the, sutures. So that's cephal hematoma. How do you differentiate between caput and also cephal hematoma? So caput ni dia tak boggy sebab dia bukannya, it's just an edema. Tapi kalau cephal hematoma ataupun SAH, subapopneuritic hemorrhage, is bleeding, so dia fluid, so you akan rasa dia boggy, dia tender, kan? Dia bleeding dalam tu, dia ada blood, so dia akan is boggy. There's bogginess and it's tender. Cuma cephal hematoma doesn't cross midline, doesn't cross suture. Tapi subapopneuritic hemorrhage, it is bleeding below your aponeurosis, it's subapopneurosis, above the loose connective tissue. And this aponeurosis ni is an area that covers the whole body. Kalau siapa yang biasa melapah daging korban kan there's this space yang you separatekan the skin tu, there's a yang white punya area tu, yang kita separatekan kulit daripada ni kan, there's this white area yang you separatekan. So that is the aponeurosis. It's just above the loose connective tissue. And bleeding daripada subapopneurosis ni is a venous bleeding. It's a shearing of the vein. So the problem with, kalau capillary punya bleeding, macam skin punya bleeding, it's easy to stop. You compress, dia boleh stop. If arterial bleed, dia mula sputter banyak. Tapi you remember artery, dia boleh vasoconstrict. Bila boleh vasoconstrict, dia boleh stop. Tapi with venous bleeding, dia tak ada good muscle. Muscle dekat your vein is not that strong. So the problem is bleeding ni susah nak stop. So this is what happened in subapopneuritic hemorrhage. And subapopneurosis tu is a continuous space, continue the whole of your body. So you can lose 100% of your blood into the subapopneurotic space. You can lose 100% of your blood into the subapopneurotic space. So that is why SAH ni can be a problem. We've seen babies deteriorating because of SAH. We've seen babies that are having severe anemia because of subapopneuritic hemorrhage. Ataupun the other term for SAH is subgaleal hemorrhage. Subgaleal hemorrhage. So it's basically the same thing lah. Subgaleal hemorrhage ataupun subapopneuritic hemorrhage. Again, how do you differentiate between cephal hematoma and subapopneuritic hemorrhage? Macam mana?
It crosses the midline.
Yeah, it crosses the midline. It crosses the suture. SAH crosses the suture. Then daripada kepala kita tengok kat mata pula. So mata itu apa? Itu eye placement, size mata dia slanting ke tak, up slanting, down slanting. We look at the red reflex. Sometimes we miss congenital cataract. So make sure baby ada red reflex present, bilateral eye, mesti buat. We look at epicanthal folds, blink, whether we tap glabella tap, dia ada blink tak, ada discharges tak, pupil reaction dia macam mana, can the baby follows midline ke tak bila you gerakkan kepala dia macam mana. So we look at the eyes because sometimes ada banyak benda yang kita boleh miss dan very important things. I've seen babies with congenital rubella, I've seen babies with congenital CMV, sometimes they only present with congenital cataract, congenital cataract. So hearing, we assess whether the baby responds to sound, we do Morse reflex. So sometimes the babies, bila you buat bunyi je, dia akan buat Morse reflex. So dengan bunyi je, you clap the hand, tiba-tiba dia buat Morse reflex. And sometimes you look for placement of the ears. Make sure ears tu ada pina dia normal. Lepas tu kena ada external auditory meatus. Ada telinga tapi ada lubang tak telinga dia. I've seen sometimes people missing external auditory meatus, kan? Sebab dia nampak pina telinga dia nampak macam normal, but actually there's no hole. So make sure that there is a bilateral external auditory meatus. So generally in many hospitals, especially in developed countries, it's a universal hearing screening. So semua baby akan ada check hearing. Tapi in Malaysia we don't have that facility yet lah. We only do hearing assessment on on certain babies. Babies yang dapat gentamicin, baby yang dapat certain ototoxic drugs, babies yang have severe jaundice. So these are the babies yang, or babies yang ventilator. So these are babies yang kita buat hearing assessment. Tapi kalau tak semua baby buat. Ideally semua baby patutnya dapat newborn universal hearing screening. Okay, next is assessment of respiratory and cardiovascular. So scalp, mata, hidung, telinga, you tengok mulut dia, jangan lupa tengok mulut dia. Mulut dia you assess apa? Tengok mulut dia okey tak, form mulut dia macam mana, ada palate dia okey tak ke, ada cleft palate, ada cleft lip ke apa ke. Kadang-kadang ada lahir, ada gigi, kita panggil natal tooth. Natal tooth is normal lah. So kita tengok benda macam tu. Palate yang penting dia, palate dia macam mana, ada cleft ke tak ada cleft. And then you go down, you tengok dia punya chest dia, respiratory and cardiovascular, assess whether there's any need for cardiorespiratory support. You tengok chest dia ada abnormality tak, ada pectus deformity since birth ke tak ada any hyperdynamic precordium ke tak. Biasanya murmur the first 5 days of life ni is a bit difficult because especially benda macam VSD, dia tak ada murmur lagi. Kenapa tak ada murmur lagi VSD? The first 5 days ni VSD punya murmur you tak dengar lagi. Kenapa? Siapa-siapa boleh cakap? Why? Lukman Sabaran. Kenapa?
I think because of the pattern of the ductus atrosus, betul?
Wrong. Ikhlas Solehah. Why?
I'm not sure, Doctor.
Nur Fatihah, Mak Yasim. Okay.
High pressure.
High pulmonary pressure.
Oh, excellent. Good answer. So, again, I'm not sure you all have had bedside teachings with me or not. Ada ke? Tak ada lagi? Tak ada lagi? Tak ada lagi? Okay, so kalau tak ada, again, I don't know how we're going to do our bedside teachings with COVID and so on and so forth, but remind me, hopefully we can do some sessions. Kita boleh buat online je pun, discuss about physiology behind clinical signs. Kenapa ada murmur, kenapa ada wheezing, kenapa ada ni. If you understand physical science, pathophysiologically, it will help you to understand. Okay, nanti insyaAllah remind me kita buat session. Benda tu boleh buat online je. So COVID kita COVID we can do. Weekend pun kita boleh buat. Okay, so the basic is that murmur, you can hear murmur when there is turbulent flow. Murmur is caused by turbulent flow. Turbulent flow creates vibration. That's why you can hear. So kenapa ada turbulent flow? Turbulent flow happens when there is a shunting, left to right shunt or right to left shunt. So shunting happens bila ada pressure gradient. Shunting daripada something yang high pressure to lower pressure. So there's a flow. Kan? Always flow macam tu, from high pressure to low pressure. So that's shunting. That's how things move from high pressure to low pressure. So the problem in newborn babies is that dia punya pulmonary pressure dia is still high. It takes a few days, it takes 5 days lebih kurang untuk dia punya pulmonary pressure to reduce to the normal. Kan? Sebab in utero, we've discussed before, in utero, pulmonary pressure is high. So bila pulmonary pressure is high, dia punya left side, systemic pressure and pulmonary pressure is almost the same lagi. So bila almost the same, dia tak ada shunting. Bila dia tak ada shunting, dia tak adalah murmur. Kan? And it takes 5 days. So sometimes you dengar sikit kan. Baru after 5 days baru you dengar betul-betul. PDA murmur pun sama. It takes, usually you won't hear PDA murmur until after 5 days. Kan? So sebab apa? Sebab dia punya pressure, when there is symmetrical, when there's when the pressure is the same, so there's no shunting. So when there's no shunting, there's no turbulent flow. When there's no turbulent flow, there's no vibration, then there's no murmur as well. And then you assess the femoral and brachial pulses. You need to make sure that you can feel the femoral pulses. What happens? Boleh siapa-siapa bagi tahu one diagnosis if you cannot feel the femoral pulse? You rasa brachial pulse, you rasa apa?
Coarctation of aorta.
Coarctation of aorta, yes. So coarctation of aorta. So kena rasa femoral pulse. And then you look at abdominal breathing. So babies, dia macam men kan, men are abdominothoracic breather. Female generally is thoracoabdominal breather. So newborn babies pun biasa dia abdominal thoracic breather. Sebab our main muscle for respiration is actually your diaphragm. Diaphragm is the most important muscle for breathing. So your diaphragm. And then satu lagi, newborn babies ni, they are obligate nasal breather. Dia breathe only through their nose. Dia tak pandai bernafas. You buka mulut dia pun, dia tak pandai nak breathe kalau you sumbat hidung dia. Because they are obligate nasal breather. They only breathe through their nose. That is why sometimes even with nose blockage, dia boleh jadi sinus. Sebab they don't know how to regulate breathing with their mouth. So dia kena bernafas dengan hidung. So kita check benda-benda tu semua. Benda ni semua benda yang we need to do physical lah. Nanti insyaAllah kita buat face to face proper punya. We'll try and do some. So chest recession, breathing, nasal flaring. Okay, next you feel for brachial pulses and also femoral pulses. Musculoskeletal, then you check the whole body. Kan, mesti simetri. Tangan kena ada dua-dua. Kan. Kena ada radius, ada ulna, cukup jari dia. I have seen people missing polydactyly. Kan? Maknanya kita jumpa at 1 month, rupanya this baby ada 6 fingers on one hand. Kan? So how can you miss things macam tu? Kan? Make sure baby has complete fingers and toes. Kan? There are many diseases. Kan? Look for the palmar crease. Ada single palmar crease macam Down syndrome ke apa ke kan. And clavicle, kadang ada clavicular fracture. We've seen people missing clavicular fracture. Movement of the arm, it should be symmetrical. Kalau ada paucity of movement over one side, probably there is shoulder dystocia, clavicular fracture and so on and so forth. So make sure the movement are symmetrical. Hips, we do buat otolani and balo test to look for clicky hips. Clicky hips may be a sign of dysplastic hip. Hip dysplasia, and then we look for clubfoot, CTEV, congenital talipes equinus varus. So CTEV, congenital talipes equinus varus ni dia boleh, it can be anatomical or it can be functional. Functional ni sebab baby sometimes, contohnya babies yang breech, for example kan, dia punya kaki dia selalu kena tekan dengan the uterus tu, sometimes dia deform macam, tapi you can easily move the foot to the normal position, then that's no problem. Physiotherapy okay. Sometimes, but if it's a fix, if it's an anatomical CTEV, you need to do more things. You need to do proper physiotherapy, then you need sometimes you do need to go for surgery. Kita kena refer lah pada our Mr. Syukrimi, Dr. Adila to do tendon release, for example. So to CTEV. Sometimes dia bukan clubfoot, sometimes dia ada clubfoot or congenital talipes equinus varus. Sometimes dia boleh ada congenital talipes Allah, I can't remember. The opposite of clubfoot tu. Allah, I can't remember, sorry. And then you look at the back. Curvatures dia, sometimes dia ada lordotic ke, scoliosis, can even happen in newborn babies. Ada cyst tak dekat body dia, ada dimple, sacral dimple. So sometimes sacral dimple is a sign that the baby has spina bifida. Spina bifida for UI student, very important to note. There was a time when we don't put, for professional exam, we purposely do not put spina bifida for UI student, because for several years UI student perform very poorly bila case dapat ada spina bifida ni. Sebab sometimes spina bifida they can cause neurological problem kan. So kena tahu lah. Agenesis kan. So sometimes there'll be a problem with neurological. Dia boleh apa dia panggil tu, bukan quadriplegia, diplegia. They can have diplegia. So hip you do, then balo you move the hip back inside. So otolani and balo test. hip check, you look at the back, you look at make sure you check the anus. We've seen people missing imperforated anus. Imperforated anus pun boleh miss. Kan? Macam mana tu? I've seen people after seminggu mak complain baby tak buang air lagi. Sebab tengok rupanya lah the baby actually has imperforated anus. Kan? Sometimes satu lagi dia ada anorectal, dia ada fistula between the anus, between the rectum and also the vagina. Kan? Dia ada fistula. So sometimes dia boleh pass meconium, tapi pass meconium through the vagina rather than through the anus sebab dia ada imperforated anus. So make sure you do check the anus. Dulu-dulu when I was a houseman, we do check using the thermometer, bulb thermometer yang bulat sikit tu. Don't use that anymore. Sebab thermometer dulu dia ada mercury. Now we are not allowed to use mercury punya thermometer. So you check guna rice tube ke kalau perlu. But basically you just examine, look at the anus pun is actually should be good enough lah. So check for anal imperforated anus. Genitourinary, make sure the baby is male or female. Anything you rasa macam tak berapa sure kan. So bila ada zone saja, make sure that you escalate it. Maknanya any abnormality of the genital, it's always something of emergency. You tak boleh kata macam ni macam tak berapa sure tapi mungkin ni, you assume. No, you cannot assume. Kan, gender is something that you need to be sure. You tak boleh macam mungkin ni nampak macam ni kan. No, you must be very sure, male or female, because there's a lot of implication, naming for example, and certain things, even benda macam certain things you can have diseases macam CAH. And CAH can be life-threatening. Children can die because of SAH, especially salt losing CAH. Kan? So make sure that you actually know. And ambiguous genitalia is a neonatal emergency. Ambiguous genitalia is a neonatal emergency. Pseudo-menstruation. Pseudo-menstruation ni maknanya apa? Newborn babies, you nampak ada bleeding, breakthrough bleeding. That is pseudo-menstruation. So pseudo-menstruation ni, yes, why? Because of hormonal, because of hormones. Lepas tu, because of hormone juga, babies boleh dapat gynecomastia. Dia punya breast bud dia besar. Not because of, not a problem, it's just because of maternal hormone. So baby tu jadi gynecomastia, which is also a common finding lah. Passage of meconium, make sure the baby can pass meconium, make sure the placement and patency of anus, and then abdomen should be soft, non-tender, it should be round but not distended, bowel sound should be present, and then umbilical cord, make sure dia ada 2 artery and 1 vein. Kalau dia abnormal, then you need to look for things. And then skin, tengok ada acrocyanosis tak, ada desquamation tak, Epstein pearls, erythema toxicum, harlequin color, milia ke, these are all normal actually, Mongolian spot or port wine stain. So kalau ada port wine stain ni, you need to think what is the diagnosis kalau ada port wine stain. And then look for jaundice, kan, especially if the jaundice appears the first 24 hours, then it's always pathological. Jaundice, the first 24 hours is always pathological. Jaundice is basically yellow coloring of the skin, and it's very common and it's caused by natural breakdown. It's physiological. But the first 24 hours is always abnormal. After 14 days in term or 21 days in premature, it's always abnormal as well. And then usually it peaks around 48 to 72 hours if it's physiological. Usually it should disappear around 1 week or so. Mostly it's benign, but if it's severe, it can result in so many things. I've seen maybe one of the common cause for deafness, hearing abnormality is sometimes because of severe jaundice. And then we look at the nomogram. Easiest is you look at the pediatric protocol. Dalam pediatric protocol, I think page 124 ke macam tu, ada mention pasal jaundice. You nampak dia punya nomogram dia. Phototherapy, so you put the baby under blue light. Kena blue ke? Boleh tak? White light, red light ke? Boleh tak? Why blue? Yellow light boleh? Siapa nak jawab ni?
Sebab spectrum of light tu sama dengan UVB.
So basically because of the spectrum of the light, it's not about UV. You're not giving UV light. It's not UV light. It's a blue light. It's not UV light. So basically you're looking at the blue light because of the frequency of the light. So people are studying other colors as well. People are looking at white light, for example. There are some studies suggesting the benefit of white light. So what does the light do? Kenapa kita buat phototherapy ni? What does the light do? Siapa nak jawab ni? Nurul Husna. Kenapa kita letak lampu ni?
We want to conjugate back the bilirubin.
Unconjugated.
And
So the idea is unconjugated bilirubin. So bilirubin is the result of your hemoglobin breakdown. Hemoglobin dia breakdown into globin and heme. So heme tu dia breakdown lagi, dia jadi bilirubin lah, kan? So bilirubin ni dia memula dia unconjugated, and unconjugated bilirubin is apa? Hydrophobic and lipophilic. Unconjugated bilirubin is lipophilic and hydrophobic. So bila dia lipophilic and hydrophobic, it is not excreted through the kidney. And it is sorry. And it can cross the blood-brain barrier. It gets into the brain and cause damage. So that's the problem with unconjugated bilirubin. So, but conjugated bilirubin is hydrophilic. So it can be excreted to the kidney, it can be excreted to the portosystemic. And so that's the thing. So what it does is with phototherapy, the process is what we call as photoisomerization. So it changes some of the molecular structure of the bilirubin so that it becomes of the unconjugated bilirubin, so it becomes more hydrophilic and less lipophilic. From that, so then we can excrete the bilirubin, the unconjugated bilirubin, through the kidney. So this is what photoisomerization does. Okay, so kita ada banyak jenis lampu. Dalam gambar ni we use the fluorescent light. Zaman-zaman dulu semua kita guna fluorescent light, lampu Kalimantan. So the problem with fluorescent light ni adalah it produces heat, panas. So that's why babies sometimes dia burn, dia dehydrated, hyperthermia, fever, tachycardia, so on and so forth. And dia hyperthermic, dia produces heat. Kan? And it uses lots of energy as well, lots of electricity. Sekarang ni most hospital kita tak guna dah fluorescent ni. Susah nak maintain, costly. Sekarang kita banyak guna LED. So kita guna LED. So with LED you can produce more light with less energy. The only problem with LED is that it doesn't produce heat. Dia tak produce heat. Bila dia tak produce heat, the problem dia, our NICU are usually cold, sejuk. NICU kita sejuk untuk reducekan risk of sepsis, apa semua, reducekan infection. So dia sejuk. Bila LED tu, dan untuk exposekan baby, kita kena bogilkan baby tu pakai nappy dia kan, buka baju dia. Kan? So the problem is when you letak light source yang tak produce heat, where can the baby get heat? So sometimes our babies kalau kita tak buat proper, dia boleh jadi sejuk. Kan? Dia jadi irritable sebab dia sejuk kan. So dia tak tolerate feeding sebab dia sejuk. So kita kena ada mechanism macam mana untuk kita maintain thermoregulation. So this is phototherapy. Dan kita ada banyak mechanism lain. Satu LED, kita boleh guna fiber optic juga. Kita ada kat our unit ni fiber optic. Kita guna Billy blanket atau Billy bed. So, alright, the exchange transfusion, we're not going to go there. And then sometimes if you look at the eyes, dia boleh ada subconjunctival hemorrhage. Ni gynecomastia, which is normal as well. Ini cord yang dah ada knotted kat situ. Apa ni? Gambar atas ni. Huh?
Mongolian spot.
Mongolian spot ini.
Spot
Or
one.
maybe pot
Spot one
one
stain.
stain. Yes, pot one stain. Yang ni?
Milia.
Milia.
Milia. Normal ke tak normal?
Normal.
Normal ni.
Hemangioma.
Capillary hemangioma, strawberry hemangioma. So which is also not really a problem kan. Sometimes dia akan membesar dulu for few months and then after 8 months, 10 months dia akan start to regress. And then CTEV. Okay, alright. So you do a head to toe examination. We're not going to go there. We look for spina bifida and then carefully urogenital abnormalities. Okay, so sometimes there are certain congenital abnormalities that will spontaneously resolve. Cyanosis, traumatic cyanosis ni boleh settle. Distorted head shape, kepala dia kalau dia molded ke, sometimes kepala dia akan abnormal shape. Yang tu pun akan settle lah. Subconjunctival hemorrhage pun akan settle. Sometimes dia boleh ada gum, cyst, tu pun boleh settle sendiri. Breast milk enlargement, apa nama, breast enlargement, apa nama, gynecomastia, sometimes boleh ada produce milk pun, but that is because of maternal hormones and it is normal and will resolve spontaneously. Capillary hemangioma as mentioned before. Okay, that's it. Clear? So basically newborn examination, kalau if you do other examination, other physical examination, those are examination on a, when you do physical examination, you have something you want to look for. You need to know what are the differential diagnoses. Then you look for those things. You look for the specific signs. If a patient presented with shortness of breath, sore throat, then you go and look for those things. Look for the signs for that differential diagnosis. You look for the provisional, you look for the differential, you look for the complications of the disease, you look for complications of the treatment. That is in other cases. But for newborn exam, you are doing examination on a normal child. You do on everyone, and you know everyone, most people are normal. So newborn examination is a universal type of screening. You assess everyone, and most of those that you assess are normal babies. So again, in other examination, it's an targeted examination to look for abnormal things. But in this assessment, it's basically an assessment of normality. You expect it to be normal. So that is why it's more important for you to know what is normal and what is abnormal. Okay. Boleh tak? So yang ni pun again, it's ideal we need to do proper bedside lah. I really hope we can arrange something, we can do a proper session in small groups probably, where you can practice on newborn babies, how to do proper newborn examination. It's a head to toe, from scalp, eyes, nose, mouth, ears, neck, chest, musculoskeletal, genital, abdomen, GI, that's it. So the whole body. Okay, clear? Ada question? Ada? Fahim Tum Kalami?
Doktor,
Yes.
nak tanya apa beza yang dekat ballet score tu, yang dia punya popliteal angle dengan ear to ear. Sebab dia macam sama je.
Apa, you tengok gambar you akan nampak sama. Tapi when you do it, so yang tu kena ajar backside lah. Itu kena ajar backside. So remind us, when we assess the patient, we'll show you how to actually do, how to differentiate between popliteal angle and heel to ear tu. It's a bit different on how you do it and where you look for it. And the assessment of the knee joint and so on and so forth, how you position the baby. Anything else? So remind me. So we'll settle that by bedside. Yes.
Doktor,
Why
want to ask.
do we do ballet? Sorry.
Cepat
Can I
Farisha.
ask?
Then siapa?
Why do we do ballot score? And is there any possibility that it could be a discrepancy between the gestational age provided from the ONG and when the child is born?
Can there be discrepancy between the date given by the ONG and also the date when we do ballot score? Yes, but the thing is, what we see at on the baby is more accurate. Why is more accurate? Because the assessment is there's multiple assessment. So how do we assess date? How do we assess the date of the baby, gestational age of the fetus, for example? Dia ada beberapa cara kan. Satunya is looking at the date of amenorrhea. Kan? Period of amenorrhea. Kan? You look at period of amenorrhea, last menses, and then you kira and so on and so forth. Kan? Problem dia is some people the menses are irregular. Kan? Some people the menses are irregular, and sometimes some people walaupun dia menses irregular, sometimes the first 1 or 2 months dia boleh ada some breakthrough bleeding. Dia boleh some breakthrough bleeding, istihadah. Kan? Dia boleh some breakthrough bleeding. APH. So sometimes they confuse. This is blood. They assume dia adalah menses. Sedangkan it's actually a APH, for example. Kan? So sometimes the date. So sometimes mak tak sure date bila. Kan? Because I know some women they don't even write when is their menses punya date. Kan? They just assume je. Kan? So the date sometimes is a bit tricky. Kan? Itu satu. Some people are elusive as well. Dia saja bagi date yang lambat, date yang lepas kahwin, for example, kan? For premarital conception, kan? So sometimes dates are a bit unreliable. Next is how do we assess the gestation age? Antenatally, we assess by doing serial scan, kan? So first they kena buat dating scan. So dating scan should be done as early as possible, kan? So the later you do dating scan, the later you dapat date dia, the less reliable the dating is. Faham tak? So kalau you buat dating scan tu lambat, kan? Date tu tak reliable. You kena buat cepat. The first before 12 week, kan? Macam tu. Kan? Dan dating scan juga sometimes is done, most of the time is not done by obstetrician. Sometimes most of the time is done by MOs. Kan? Dan training MOs yang buat scan pun sometimes it's not a proper training. Kan? It's not a proper training. So that's the problem lah. Sometimes you may miss proper dating, proper dating of the baby. But when the baby is born, if we see from our assessment, the baby is premature. The baby is premature. It doesn't really matter because this is how the baby is. The baby will behave like that. If the baby looks mature, baby is mature lah, kan? So it doesn't really matter because that is what the baby is, kan? So ballot score is much more reliable as compared to other types of assessment of gestational age. It's very reliable. Why we do ballot score? Generally, we don't do ballot score on all babies. So which baby we do ballot score? We do on premature babies, babies who are unsure of date, baby that's high risk, then we do ballot score. Okay, I hope that question is answered.
Thank you, Doctor.
Siapa lagi seorang tanya tadi?
Doctor,
Yep.
kalau let's say the patient presents with hemangioma, we need to look out for other associated condition, contoh macam face syndrome tu.
Yeah, of course. If the baby has hemangioma, you can just, it's not ideal for you to just say, oh, ada pot 1 stain, and then you ignore. You nampak ada something, kan? Ada cafe ole, and then you ignore cafe ole, you document cafe ole. No, you need to look for other signs. You need to look for other association, kan? Sometimes because I've seen children who has lots of hemangioma. Dekat muka ada hemangioma dekat liver. I've seen babies with hemangioma in the brain and causing high output cardiac failure. So that's it. So you do need to look for things. Tapi kalau ada potong, cubit dia hemangioma dekat tangan ke, kan? Sometimes it may not be problematic lah. Because again, hemangioma, vascular abnormalities are high resistant punya high resistant or low resistant punya circulation. So all this can result in problem lah. If you have lots of hemangioma, it can cause high output cardiac failure.
Alright, thank you, Doctor.
Okay, lagi next. Okay, faham lah tu kan. Tak tanya tu maknanya I assume semua understand lah. Semua dah ready lah untuk buat. I think again newborn ni you won't get it in exam. You won't get neonatal question in exam, but you can get in theory exam. In theory exam we can ask you lah. But again this is just a basic assessment of all newborn babies. It's a universal type of screening. All newborn babies must have newborn exam. All. There should not be any newborn babies not getting any type of newborn exam. Cuma who does the newborn exam, there's a thing. Sometimes it's done by midwife, sometimes it's done by doctors. In Malaysia, generally all babies must be seen by doctor. All babies. There should not be any babies in Malaysia not seen by any doctor. So that's the thing. Okay, all right. Clear? Okay lah hopefully we can arrange a proper face-to-face session with you guys to do proper physical examination. We do have some interesting babies in our ward, inshallah. Okay, all right, that's it. Okay, let's end our session with tasbih kafarah and suratul asr. Assalamualaikum.